So a lot of this discussion has been led by my colleagues and the previous faculty. These are my disclosures. I do consult and advise numerous companies that are manufacturing and developing venous and pulmonary embolism thrombectomy technology. But this is a major, major burden on not only the United States healthcare system, but on the global healthcare system. Not to belabor the point here, we are diagnosing hundreds of thousands of pulmonary embolisms in the United States every single year. It's widely considered to be the third leading cardiovascular disease in North America and the leading cause of hospital-related mortality. And so it really demands that we think outside the box and come up with a novel strategy, a novel technology. And the concept that I think there's been so much enthusiasm for is that can you create a minimally invasive percutaneous solution that would avoid a patient receiving a high-dose lytic infusion. Obviously, Alteplase has been FDA approved for the treatment of acute PE for many years now, but it hasn't achieved wide favor due to safety concerns. Can you avoid putting a patient into an ICU to receive a lytic infusion overnight? Can you acutely lower the pressure in the right ventricle and in the pulmonary artery? Can you acutely improve the right ventricular function? And can you rapidly extract clot from the pulmonary circulation and restore normal perfusion? And can we do it safely? I would argue we cannot do this yet, despite all the incredible speakers from the last session. But if we could, would that change practice? And I would argue that it probably would. The reason that I would say we're not able to do it safely is this: we would have level 1 guidelines that would advocate for us doing this on a routine basis. And we certainly do not have level 1 guidelines endorsing the use of minimally invasive treatments for acute pulmonary embolism. Even surgery or percutaneous treatments only have a 2A recommendation in the treatment of patients who decompensate hemodynamically. So we really do have a long ways to go here. Another, again, 2A recommendation, even for patients with contraindication to fibrinolytic agents. And again, just a number of 2A or even lower recommendations for percutaneous therapy for patients who fail anticoagulation therapy or are viewed to be unstable. So where are we in 2022? We have 3 on-label devices. These have been referred to by the previous speakers. We have ultrasound accelerated thrombolysis, the FlowTriever system, and the Indigo system. The ultrasound system, not to belabor the point, was FDA approved almost 7 years ago, and this is widely considered to be the start of the minimally invasive or endovascular era. This was followed by the publication in JACC in 2019 regarding FlowTriever, and then 2021 regarding Indigo. And so we're at an era where we have a number of tools. I don't believe anybody believes that they are perfect. And we're starting to see a revision of the European Society guidelines. This article was published in Eurointervention just 2 weeks ago or 3 weeks ago now, where they're saying that there is a role for catheter-directed therapy. CDT here is not catheter-directed lysis, it's catheter-directed therapy, but it should really be only considered in failure of anticoagulation and then hemodynamic decompensation. And so those are sort of where we are. And obviously that's why there's so much a flurry of attention for novel technologies and novel therapies. Not FDA approved yet, but Dr. Tzlakian reported on this. This is likely will be approved because it was effective and it was safe. A novel technology which opens up an occluded vessel and is able to disperse a fibrinolytic agent probably very, very rapidly and effectively. And then again, Karin mentioned this, but a very, very large series demonstrating safety of the Inari FlowTriever system. So we're moving in the right direction in terms of data, but there's a lot of work to be done. And not to belabor the point, but these are the sort of 5 trials that have been ongoing or are currently and enrolling right now for the treatment of acute pulmonary embolism. The single-arm trials, FLASH, FLAME, STRIKE, RESCUE, and APEX are demonstrating mostly safety for specific endovascular technologies. 2 have completed enrollment, including RESCUE and FLASH. FLAME, STRIKE, and APEX are either about to start enrolling or are currently enrolling. And again, previous speakers have spoken about what what these studies are designed to study. This is busy, and I apologize, but it is the clinicaltrials.gov list of every randomized controlled trial that is designed to evaluate treatment for acute pulmonary embolism. Notice only 2 of them are evaluating ECOS as an FDA-approved technology, and then Peerless is evaluating FlowTriever in a randomized controlled trial. And so again, these are currently enrolling, but there's clearly a lot more randomized trials that we need to be doing. We don't know what the role is of CDT or thromboaspiration for acute PE with any level 1 evidence whatsoever. We hope it can improve clinical outcomes. We hope it can be used for rescue therapy, but until we have level 1 evidence, we are really just sort of making it up as we go along. Is there an opportunity to use one or the other with clear level 1 evidence? Is there an opportunity to use both? What about quote unquote combination therapy, which I think people are starting to talk about more, in that you have a mechanical solution, but at the same time, you're giving low dose fibrinolytic agents into the pulmonary bed to restore perfusion. We don't even know what the procedural endpoints are, and that's unfortunately how humbling this all is. Is it the hemodynamics in the room on the table? Is it the patient's vital signs? Is it some marker of perfusion to the pulmonary circulation? And are there different anatomic features that come into play here? This slide is going to probably be shown many, many times for the next several years, but it's basically trying to reflect how effective these endovascular technologies are of taking the strain off the right ventricle as using the surrogate, the RV to LV ratio, and they're more or less all the same. And so I would put forward, if everything works, how do we figure out what is actually indicated, and how do we figure out whether or not it's truly better than just anticoagulation alone for specific populations? Obviously, we've seen a tremendous evolution in this endovascular technology. We've sort of started with, the aspiration and vacuum systems being small bore, but now they're going to be moving up quickly to large bore. We have stent-triever systems, as demonstrated in that last case, which are predominantly been large bore. Again, angiovac, the sort of vein bypass and blood return system being large bore. But what does the future hold? We don't know. Aspiration and volume technology, again, is going to go large bore. Thrombolysis infusion has been small bore, but how do we sort of marry all of these, and what are they going to look like? We just don't know what the future is going to hold, but there's a tremendous amount of enthusiasm and attention here. We also can't possibly believe that one technology is going to address all of this anatomy, as I'm showing here. There are dozens and dozens of pulmonary vascular segments, and I would humbly put forward that endovascular operators have only been focusing on this area for the last 3 or 4 years, and we don't really have a reliable, safe technology that can go past these sort of virtual margins that I have created here. So there's at least 9 technologies. This is not meant to be an exhaustive list. It's purely meant to explain to you how explosive the interest is in this area. But these are all technologies that will likely be coming to an IDE trial near you sometime in the near future. And there are likely many more. And literally just in the last week, I've been contacted by 2 other companies that want to find out what are the options to enter into the current marketplace. We have 4 either enrolling or planned randomized controlled trials, which is a huge step in the right direction. I've listed them here. This is a tremendous advancement because as recently as 3 years ago, we had 0. And so the fact that we have 4 RCTs either currently enrolling or underway is just a monstrous step in the right direction. And I think we all need to be enrolling in randomized controlled trials to move this forward. In addition, the PERT Consortium, and I was honored to serve as president just recently. We met with the FDA earlier this year. Many people who were in this room were with us with the FDA. This was a partnership between physician leadership, public health advocacy organizations, again, the Food and Drug Administration, and industry, including pharma, artificial intelligence, and endovascular device manufacturers, to come up with guidelines about how we should be recording patient safety and efficacy data for the entire journey of the PE patient, ranging from the initial assessment all the way to post-discharge management. And we are making recommendations recommendations for new data definitions and new data elements that will be reviewed and go into hopefully future IDE studies or pivotal randomized trials as well. Just as an example, this is a dozen or so or several dozen different data elements at the initial assessment, many of which are not being currently recorded in the IDE study, so we can try and identify which demographics are being best suited by minimally invasive technologies. A number of different variables looking at the quote-unquote interventional management, very, very focused on adverse events, which has been a great concern amongst the entire medical community for the last several years. What are the specific definitions of procedural and clinical success in both stable and unstable patients? And again, doing a very, very deep dive into adverse events, which we have concerns are being underreported. And I think until we get a good grip on what these adverse events look like and who's at greater risk for having adverse events, we're not going to be able to move the field forward. This is a timeline. I think somebody else has shown this slide of, we started at the turn of the millennium with intravenous fibrinolysis, and now we're just getting into level 1 evidence here 20 years later or so. Just as version of comparison, it took over 15 randomized controlled trials to be completed to get stroke thrombectomy considered to be standard of care. So there is a lot of work that needs to be done. However, the reality is that endovascular therapy is taking on an increasing role in our therapeutic options as pulmonary embolism response team members. We're moving in the right direction, but we need a lot more data. Data has to be prospective, retrospective data, or ad hoc registries can't really solve this. And we need a lot more randomized data for high risk and intermediate high risk patients. There is a long road ahead, but I think it's going to be an incredibly rewarding journey. Thank you for your attention.